All right, this week we are talking about lines, leads, tests, tubes, and equipment. It's a lot of information, so we're going to break this lecture down into two parts. So this video is going to talk specifically about oxygen and respiratory matters. These are our learning outcomes. After this video, you should be able to identify various oxygen delivery devices and distinguish the differences between them, understand different methods for trach placement, identify how to determine if a patient is ready for a speaking valve, and explain why this information is important for a medical SLP and the importance of other members of the medical team. All right, so here is a quick overview of all of the oxygen delivery devices that we are going to talk about. It's important to know that oxygen is considered a medication. You will encounter people who have a wide range of oxygen requirements when you're working in medical settings. This applies to pediatric populations and adults. It also applies to all of the medical settings. As a medical SLP, you're going to have to be fairly well versed in respiratory needs, whether you're working in the ICU, in outpatient, or home health. Depending on your setting, you're going to have a different experience and probably comfort level with different oxygen delivery devices. For example, if you're working in the ICU, you're probably going to encounter a lot of people who are using a ventilator for oxygen support. If you're working in the outpatient setting, it would be more likely people who are using a nasal cannula. You don't have to be the respiratory expert in any of these places, but you do need to have a solid foundation of information and be able to identify people on the medical team who can help when you have questions or when your patient needs more support. So before we talk about each one, it is important to understand how and why the medical team would decide on a particular oxygen delivery device. It is going to be an order from the doctor. So just like we mentioned, oxygen is considered medication. But to make this decision, they gather information from people like the patient, nursing, respiratory therapy. We aren't going to dive into the nitty-gritty of respiratory stats in this video, but you should know the term FiO2. This is the abbreviation for fraction of inspired oxygen, and it's really another way to say the concentration of oxygen that's being inhaled. So normal room air has an FiO2 of 21%. So when you take a breath and you're just breathing in the air around you, 21% of it is oxygen, another 78% of it is nitrogen, and then the other 1% is trace elements like argon, carbon dioxide, neon, helium, and methane. So if a patient is having trouble with oxygenation, that means they need a higher FiO2. So they need to breathe in air that is more richly concentrated in oxygen than just normal room air. Different oxygen delivery devices are going to deliver different ranges of FiO2. So depending on the person's need, they would use a device that can provide minimal to maximal assistance in increasing their FiO2. Another reason someone might need to be on oxygen is if they're having difficulty with ventilation. So this is someone that needs a higher flow of oxygen. We can only breathe in so much air at a time. It's going to be maxed out by our peak inspiratory flow. The normal range for this is around 20 to 30 liters per minute. So that's essentially the rate you are taking in air every time you inhale. If you're doing something to really challenge your respiratory system, like going out for a run or experiencing respiratory failure for a medical reason, your body is going to try to suck in more air. So that peak inspiratory flow is going to rise to meet the needs of your body. So one way to meet this need with a device is by increasing the flow, or liters per minute, of oxygen being delivered. So think of increasing the flow as if you were to stick your head out of the car window. So now you have a ton of air blowing at you. It makes it easier to breathe because it reduces the effort that you have to take to suck in that air around you. Okay, so keep all of this information in mind as we talk about each device. So we're going to start with the one that I'm confident that all of you have at least seen. This is the nasal cannula. So this is a low flow device that's used for people with mild hypoxia. It uses the nasopharynx as a reservoir for oxygen. The patient breathes in oxygen-rich air. It mixes with the reservoir air and it enriches the overall oxygen content. A nasal cannula delivers oxygen that has 24 to 30% FiO2. So remember, normal room air has an FiO2 of 21%. So when a patient breathes air from the nasal cannula, they're breathing in air that is a bit richer in oxygen than air they would just be breathing in from the environment. A nasal cannula can deliver air at a maximum of 4 to 6 liters per minute. So it doesn't always have to be set that high. That's just the max. Some people might be on a nasal cannula at maybe 1 or 2 liters per minute. But overall, this device can give people just a small burst of increased support. All right, along the same lines exists the high flow nasal cannula. You'll see this abbreviated in the chart as HFNC. This is the same delivery method and location as a regular nasal cannula, but the tubing is stiffer and heavier. So this one tends to kind of pull down on the face a bit more. It's sometimes more obtrusive for the person to wear. That strap around the back of the head should be pretty tight so it can kind of help keep those prongs secured into the patient's nostrils. It does tend to shift or slip a little when the patient is talking or moving around. You'll also really want to keep an eye on it if they're eating. So I'm sure you discussed this in your dysphagia class, but there are sometimes questions about swallowing while on high flow nasal cannula. Decisions about this are obviously very patient specific, and really it's essential that you do an MBS or a FEES while they're on high flow nasal cannula so you can understand the impact on swallowing if it has one at all. The high flow nasal cannula does have some other differences from the regular nasal cannula. It delivers humidified and heated oxygen. So this is helpful to keep the nasal passages moist. People tend to complain about dry and irritated nostrils and nasal passages when they have just a regular nasal cannula, because that one's just pushing in oxygen. So it's just like blowing in air to their nose. Another difference is the control of FiO2. So the nasal cannula can deliver up to 100% oxygen. So the person who controls the settings can dial in the FiO2 to each patient's particular needs. It can also deliver oxygen up to 60 liters per minute. So this option can deliver quite a bit more flow in comparison to the regular nasal cannula. All right, moving along to the simple face mask. This is a low flow device as well. It delivers 30 to 40% oxygen. So that's your FiO2, and it maxes out at 5 to 10 liters per minute. You can't control the FiO2 on this device. The benefit to this over the regular nasal cannula is really in its delivery method. So this simple mask covers the nose and the mouth, so the person on the receiving end can inspire air from either passage. This is pretty helpful for trauma patients because sometimes they have facial injuries, so it kind of restricts the air that they can breathe in from their nose. It can also be helpful for people who have sleep apnea or people who tend to breathe from their mouth when they're sleeping or when they're awake. This device, it's obviously a little bit more intrusive to wear. So people can talk and eat when they have it on, but the mask obviously gets in the way. So sometimes people will pull it off or they'll push it down or to the side or something. So sometimes people need reminders to keep that mask in place. And then again, you have those straps that go around the back of the head. So you want to kind of make sure that those are pulled fairly tight just so there's a better seal around their face and the mask stays in place. All right, the non-rebreather mask is another device that covers the nose and the mouth. This one's also considered a low flow device, but it's a little bit more complex of a system than just a simple mask. The non-rebreather has a reservoir bag attached to the mask. It's attached with a one-way valve. So the oxygen flows from the source. So if it's hooked up to like an oxygen tank, or if you're at a medical facility, like if you're inpatient or rehab, it's usually coming from the wall. Anyway, the oxygen flows from the source into that reservoir bag. The one-way valve connects the bag to the mask. So when the person breathes in, the oxygen moves from the bag into the mask. That seal around the face and the one-way valve make sure that the person is only inhaling oxygen that's coming from the source. Okay, so they're not taking in just room air. The non-rebreather can deliver 60 to 91% oxygen, and it goes at a rate of up to 10 to 15 liters per minute. Here's another mask that covers the nose and the mouth. This one's called the Venturi mask. It is a high flow device, and it's considered a fixed performance device because it allows for constant delivery of FiO2, regardless of what the patient's respiratory rate or flow pattern is. So this mask allows for the FiO2 to mix with the room air. So you can see it has those little holes in the mask that kind of allow for that. The top picture on this slide shows a child with a Venturi setup that allows for adjustments with that single valve attachment. So you can kind of see the numbers on that valve. So that one valve can be adjusted to fit that person's needs. More commonly though, the person will have one of these colored valves in place. So you can see those in the bottom picture. Each color of valve indicates a specific flow rate and FiO2 that the device delivers. So you don't need to memorize the colors or their amounts, but I just wanted you to see them just so you could get an idea of how much support that this device can provide. Okay, so we're going to move along to trach masks now. This is also considered a high flow device. It can help deliver oxygen itself and or humidified air. This is important for people with trachs because it does help reduce plugs. Okay, so people with trachs might use this because they also need oxygen or ventilation support, or they might just be using it to keep their trach site moist. Okay, so the amount of secretions that come from a trach really vary quite a bit, but no matter how much secretions that person has, you do not want them to dry up or harden because otherwise that's going to cause a blockage, right? It's going to block the trach and then that person won't be able to breathe. So wearing a trach mask is pretty important. Okay, so backtracking a little bit more from there, I wanted to talk a little bit about how trachs can be placed. So how a trach is placed can sometimes impact when you can begin with speaking valve trials and or a swallow evaluation. Okay, so it's always good for us to make note of how it was placed. One option for placement is surgical. So this is where the surgeon makes a dissection and an incision of the trachea under direct vision. So obviously this placement method is completed in the operating room, okay? The other option for placement, which is perhaps more common, I would say, is called percutaneous. So with this method, an incision is made with a needle and guide wire is used to dilate the trachea between the rings. Okay, then a flexible bronchoscopy, it's used to visualize and guide the process. So they're kind of looking down there with a camera while they're completing this. And it's completed right at their bedside. So for this reason, it's less expensive, it's quicker, and it eliminates any sort of scheduling complexity with a patient scheduling to get into the OR. Okay, so those are the two ways that a trach can be placed. Before you start anything with a patient who has a new trach, you'll obviously be checking in with the medical team. So having all of this information is just one piece of the puzzle. The doctor is going to place orders when they think that the patient's ready, and you'll talk to both the nurse and the respiratory therapist to get their input on the timing of when speech therapy is appropriate. So things to consider are how the site is healing, if there's kind of the amount of blood or swelling in the area, the amount and the type of secretions, if they're thick, if they're thin, if they're copious. You can look in the chart to find a lot of that information because all of it will be documented, but you also always want to have a verbal conversation with those key players of the team before you get in there and get started. Okay, the next video that you have to watch is going to discuss more procedures, but because we just talked about bronchoscopy, I thought this would be a good time to give an overview of that procedure. So a bronchoscopy is a procedure that uses a scope to look closer at the airway and lungs. As we just talked about, it can be used for trach placement. It can also be used to go down and retrieve mucus or tissue samples. It's used to remove foreign bodies or blockages and to provide other treatments. There's a thin tube. It's passed through the nose or down the mouth. It goes down the throat and all the way down into the lungs. Okay, there's a light on the end of it. And then you can also pass tools through the scope. So they can do things like take a biopsy, remove a blockage. With patients who have lung cancer, they can even use a special bronch that has an ultrasound attached, and that can check things like lymph nodes down in the chest. So a bronchoscopy can be a very useful procedure and tool that they use in the hospital. The patient is sedated. Sometimes if they're like in the ICU and they're already on sedation, they might be completely out. If they're doing a bronchoscopy in outpatient, they might still be awake, but they won't have any feeling down there. But anyway, either way, however it's done, the patient will usually need some time afterwards to recuperate before we're going in there, right? Because we're going in there to have them talk and swallow, and all of that's a little hard after their throat has been kind of irritated from this procedure. Okay, so getting kind of back to the trachs, they do come in a variety of brands. It just depends on the facility that you're at. Some of the bigger or more common ones, Shiley, Bivona, Portex, Jackson. Jackson is actually made with stainless steel. So those ones you would more often find outpatient. So they're usually placed on people who have chronic trachs because they're really easy to clean, easy to care for. If you're working with someone who has a trach, they might be on room air, or they could use that trach mask like we just looked at. They might also have higher respiratory needs and be on a ventilator. So a speaking valve can be used with a ventilator, but the patient needs to be able to tolerate cuff deflation. Okay, so this is something that respiratory therapy is going to be right there, right in there with you. They're going to help you with this whole process. They're the experts, right? So if you're working with someone on a vent, you'll notice that there are tons of ventilator modes, and you can learn more about those. You don't have to know all the specifics, but it is good to be at least a little bit familiar with ventilator modes if you're working with that population. When you use a speaking valve on the vent, some of those settings and alarms need to be adjusted. So again, hopefully the respiratory therapist will be in the room with you the whole time. And they're the ones, they kind of control the vent, and you're controlling the speaking and the therapy part. So it's really, when it works out, it's a really nice collaborative effort to help the patient use their voice. So a lot of this does depend on your facility. Some facilities are further along in the process. They use speaking valves with as many trach patients as they possibly can. Other facilities are a little more hesitant. So if this is a process that's new to the facility that you're at, or if they just don't see many patients with trachs, you might find a little resistance when you suggest doing a PMV in line with the ventilator. The good news is that you're not alone. So the PMV website is a great place to start. They have a lot of free class options that you can take, or you can direct others to take, to increase your knowledge on the respiratory system, speaking valves, ventilators, and even swallowing. They have research articles posted there as well. So that gives you the evidence base to back up all of your suggestions. You can take those to your team as well. PMV will also come directly to your facility. So they'll come and do an in-service for all the SLPs, the respiratory therapists, the nurses, the doctors. It's helpful because they can address the whole team. Passing Mirror Valve is also kind of cool because they have a lot of resources for kids. They have a Toby Tracheosaurus pediatric program. So this helps kids and families get more familiar with the topic. They have a friendly introduction to trachs with like a little stuffed animal that they send, a coloring activity book. They also have a puppet available. So if you're someone that works with kids who have trachs often, that might be something you want to add to your toolbox. That's the word. Anyway, a lot of their programs and tools are free, which is pretty cool. Okay, so that wraps up this video. Look back at the learning outcomes to make sure that you understood all of the big objectives that were covered here. If you have questions, feel free to send me a message, post on Yellow Dig, or ask when we're in class. All right, bye.